Hi, everybody. Welcome to our Vascupedia views. This episode is really unique because we will try to provide a profound analysis of the current role and the future of Sirolimus in the treatment of peripheral arterial disease. A few years ago, we probably wouldn't be here to discuss this topic since the first results of paclitaxel as regards patency and freedom from reintervention during PAD treatment led to a clear message: paclitaxel works fine in the femoral-popliteal axis. However, the safety issues regarding increased amputation rate from the IMPACT-DIP trial and the increased mortality rate from the meta-analysis of Katsanos and his colleagues changed completely the initial enthusiasm of the vascular society. Nowadays, a new debate has begun with the burning question being if sirolimus could lead to better outcomes compared to paclitaxel. To inform this debate, Vascupedia invited two really great guys and scientists from completely different fields. One from the side of design and manufacturing, and the other from the side of the clinical use and implantation. Please welcome Mr. John Shulze and Dr. Michael Lichtenberg. Gentlemen, welcome to Vascupedia Views, and thank you for accepting this invitation. Few words about our first guest. Mr. Shulze is the Chief Technology Officer of Medallions, which is sponsoring this webinar today. He has a long career in stent and DCB development for several companies over 30 years, holding numerous patents for stents and drug-coated balloons. And prior to Medallions, worked for biosensors and developed the first biodegradable polymer for drug-eluting stents and Biolimus A9 drug. We really feel honored to have you here, John, because we're going to learn a lot of important things from you today. Just for the audience, please do not hesitate to ask any question. I will try to cover all of them. And keep in mind that during the presentations, a number of polls will appear, and we kindly ask you to vote in order to discuss the results at the end. Please, John, show the first poll for the audience and share your presentation. So please take your smartphones in the desktop. Please show us the first question, and please vote the first question. Next slide, please. So the question is: the drug-eluting balloons you use today are only paclitaxel balloons, both paclitaxel and sirolimus balloons equally, mainly paclitaxel balloons, and some sirolimus balloons? Please take a few seconds and vote. What is your current practice? John, again, thank you. The microphone is yours.
Thank you, Dr. Bisdas. I'm very honored to be here today to speak to you about the SELUTION SLR, Sustained Limus Release Drug-Eluting Balloon. It represents a new technology that has been developed over the past several years at Medallions using the drug Sirolimus. As you may know, many of the products out today for treating vascular disease, peripheral vascular disease, are using the anti-restenotic drug paclitaxel. However, Sirolimus has several important advantages which we thought we could harness to provide an improved product for treating vascular disease. For example, Sirolimus is a cytostatic drug. It has a 10,000-fold safety margin. I've used it extensively in coronary stent design and know that it's a very good drug. It's a very capable drug for limiting restenosis. It has a very wide therapeutic range, which is important because, as you may know, the types of lesions that we encounter go all the way from simple to very complex with a lot of calcium and plaque, which can change the amount of drug that actually reaches the lesion. And so having a wide therapeutic range in the drug is important. It has high anti-restenotic efficiency like paclitaxel, but it has typically offered less restenotic response or a lower restenosis in coronary trials as compared to paclitaxel. And Sirolimus offers another important advantage, which is that it's an anti-inflammatory, which you don't get from the paclitaxel drug. This is important because whenever we do angioplasty, you do some injury to the tissues, and this drives inflammation. I'll talk about that a bit later. So the idea with harnessing sirolimus for a drug-eluting balloon was to enhance tissue absorption, because sirolimus is not as readily absorbed as paclitaxel, and that's why early drug-eluting designs for peripheral drug-coated balloons was using paclitaxel. It was just easier to apply to a balloon and get it to be absorbed. We needed some kind of an instant glue that would actually hold the sirolimus to the vessel wall so it had a chance to do its work over a period of time. We needed to extend tissue retention time, because we knew in the years of work with sirolimus that we needed a time release mechanism, which is typical when you use a stent. You have a coating that releases drug over an extended period of time. So we really wanted to mimic that with a drug-coated balloon design. Finally, we wanted to protect the drug from wash-off during balloon delivery and reduce the amount of embolization during balloon deployment as compared to the first generation designs using paclitaxel. So we came up with this technology, which actually comes really from the idea that when we make biodegradable coatings with drug for stents, we use a biodegradable polymer and we combine it with the sirolimus drug in a way that it forms a drug release system that can release the drug over an extended period. And in the case of this balloon design, these took the form of small 4-micron microspheres of biodegradable polymer, and there's literally millions of them on a single solution drug-coated balloon. Then we added that to a cell adherent technology membrane, which is a proprietary amphipathic lipid technology that ends up creating a very smooth surface, almost like a Teflon surface coating that is very easy to track through the vessel, because it's very smooth as compared to the earlier generation designs, which used a crystalline type drug coating, which was very scratchy, if you will, and actually could cause some injury as you delivered the balloon to the treatment site. So here's a little movie that shows you the final product with the micro reservoirs embedded in this lipid coating, the micro reservoirs containing the polymer and the drug, and then finally the lipid coating housing all of these micro reservoirs. As the lipid coating and the balloon is expanded, you see all these micro reservoirs transferred to the balloon, to the injury site, and then the micro reservoirs degrade over a period of 60 to as long as 90 days to continue to bathe the vessel with anti-restenotic drug. In Reno Vermani's lab, we actually expanded these types of balloon designs, as you can see here, and this is a pig coronary artery. The lower left-hand corner showing you electron microscope pictures of all these little micro reservoirs being deposited into the vessel wall. And we can use a much lower level of drug as compared to the previous designs like the Barton Leuconics, where we use only 1 microgram of drug compared to 2 or 3.5 for other competing products. So the safety is very high because of the high safety of the solution sirolimus coating. And yet we can get much longer extended release of the drug to continue to control the anti-restenotic process. And the delivery efficiency is much higher, which also allows us to use lower doses. Here you can see we can deliver as much as 39% while having only 36% of the drug lost during the procedure. This is much better than earlier generation designs. Sustained release is really important. If you read this article by Forrester, which was published in JACC in '91, you can see the entire anti-restenotic cascade lasts for at least 90 to 120 days. There's different phases, as you can see here. First, there's a platelet deposition over the injury site, then leukocyte inflammatory cell recruitment, which comes to clean up the injury site. Finally, there's smooth muscle cell activation in the granulation phase, and finally matrix formation, which is really the matrix that surrounds the living cells, which is actually the source of the restenosis. And that takes a long time to form, which is why your patients tend to come back not immediately, but 90 or 100, and maybe even 6 months or 1 year later, and have more stenosis. So PAD in coronary arteries is relatively quicker than it is in peripheral arteries, where it takes even longer for this whole process to complete, sometimes up to 2 years. And these coatings that you see on drug-coated balloons today are variable. Some of them are very scratchy. They have a lot of crystalline content. I'm sorry, this is advancing too quickly. And if you compare that to the solution, we see relatively little flaking and large particle release from the balloon. This is our results, 2-year results from our first-in-man study. 30 of the patients recruited from Zeller's institution, and he's going to share his 2-year data soon. The main goal of this was to show that the Sirolimus coated balloon could be effective in the setting of peripheral artery disease. And also we looked at the various safety endpoints out to 2 years. As you can see from this slide, up to a third of the patients had severe or moderately severe calcification. About a third were CTOs. The lesion lengths are relatively short in these patients, and on average 65 millimeters in length. The Kaplan-Meier curves, as you can see, very nice response to the anti-stenotic drug going out at 6 months. The follow-up late lumen losses tracked almost the results that you got post-procedure after treating the lesion. If we look at these first-in-man results compared to other first-in-man trials, Solution had a 0.19 late loss, which was lower than most of the other first-in-man results. And we had one of the lowest TLR rates at 6 months, around 4%. There was relatively low bailout stenting at 8%. So we have, I think, established with this first-in-man study that Sirolimus can be applied to a drug-coated balloon with good efficiency, low dose, and very acceptable TLR rates. So I just want to mention in brief that we do have a investigator-initiated trial that is ongoing called the Prestige trial at Singapore General Hospital. The Prestige endpoints were freedom from device and procedure-related mortality, all the typical safety endpoints, freedom from major target limb amputation, the primary patency rate at 6 and 12 months, and we also took a good look at wound healing. The inclusion criteria here were TAS C or D lesions greater than 100 millimeters, target vessel diameters in the tibial arteries between 1.5 and 4.5 millimeters. Post-op follow-up went out to 12 months post-surgery, and patients returned for 3 and 6 month follow-up visits. Walking data were collected along with other clinical signs. These are just the patient demographic characteristics. A high proportion of the patients in Singapore are diabetic, up to 80% of the population, which it makes it a very difficult population to treat, and combined with other high risk factors, especially end-stage renal failure, patients on dialysis, and 100% of the patients were Rutherford score 5. 56% were moderate to high risk for amputation under the Wi-Fi classification system. So bailout tibial stenting was done in none of these patients, and anterior tibial artery was the most commonly treated vessel. Most of the patients were TASC C or D in this population, and moderate to severe calcification. If we look at the results going out at 6 months, you can see there was very little death or amputation in this group out through 250 days. And survival was excellent at about 80%, looking out through 250 days. And wound healing, I just show you some quick slides. I think 82% of the patients had successful wound healing, and 84% were amputation free. So here's just a quick picture of some of the healed wounds at 6 months. And these are just some case studies, but I think in the interest of time, unless there's further discussion, I'll go on. Just to mention quickly that we did not see a lot of slow flow phenomenon in treating these patients. This is a common occurrence, as you know, in treating tibial arteries with other devices. And we think this is somewhat related to the fact that we have very low embolization of large particles. So we don't get a lot of drug distributed in large amounts in crystalline form down into distal tissue beds where they can inhibit healing. So I think this is an important advantage for Sirolimus, and with this particular device in the tibial arteries, and even extending down to treating small arteries in the foot. So we are working very actively on trials. You may have heard of some of our trials. In addition to the solution first in man, we have a PTA study that's enrolling, an SFA IDE study for FDA approval, as well as a BTK study for IDE approval. Prestige is continuing on in Asia with a larger cohort of 75 patients, which will add to the total knowledge about how this solution balloon works in tibial arteries. The STEP trial is the first trial with Marion Brodman to really study use of Sirolimus in the foot. So with that, I'll leave it. And I thank you very much for your attention.
Thank you very much, John. Let's see. Okay,
we
perfect.
have another, we have
Yes,
another vote now.
Question. Please take the opportunity to vote again, please, because the results of the first voting, I have already them, are really interesting. So do you believe that Sirolimus is a better drug than paclitaxel for treating PAD? The first answer is no. I think paclitaxel is the better drug. Second answer, yes, I strongly believe Sirolimus is better. Answer number 3, they are both good. Number 4, neither one is a good drug. And the last one, I am really not sure about this. Again, thank you, John. And now it is, I'm really delighted to invite Michael Lichtenberg. He's the key opinion leader at the moment. He's chief of the angiology in Arnsberg in Germany. At the moment, is probably a PI in several trials in PAD treatment, and he had one of the first experience with the new balloon. So, Michael, we are really waiting for your feedback regarding this new technology.
Yeah, thank you very much. It's a pleasure to be here today, this evening, and it's a pleasure to discuss on this new technology. And John mentioned some very important aspect of this new technology with the Sirolimus using not only in the SFA popliteal arteria, but also for CLI treatment. And this is what I would like to focus in my presentation. So thank you for giving me this title. Here my conflict of interest, my disclosures. Yeah, I also want to start with a vote. How often do you use a drug-eluting balloon to treat SFA? A, less than 10%, B, 10 to 30%, 3, 30 to 50%, or 4, more than 50%. Please vote, and we can discuss on this outcome later on within our discussion. So I leave this for a second, and I think then we can advance and dive into the topic and discuss a little bit about BTK treatment, where I would like to focus. For the SFA, we have definitely growing evidence for debulking plus anti-restenotic therapy. I think that is clear so far, definitely more data than we have for BTK interventions. We all are aware that below the knee, there are a lot of technical challenges. And this is, one part of my presentation. Treating and accepting these challenges. So from an endovascular side, meaning make it open. But on the second part, I really want to discuss with you on this second important job we have as interventionists to keep it open. So what are the challenges from an endovascular approach below the knee? First of all, it's the calcium burden. Calcium is challenging, it's different to pass. So how can we improve vessel compliance and to avoid especially complications like dissections or recoil? What about lumen gain? We already learned that lumen gain is associated with a better clinical outcome because it improves patency. So how to achieve enough and stable lumen? Therefore, my hypothesis, and this is what I would like to discuss with you, that a lesion preparation plus DCB angioplasty strategy for BTK lesions in patients with CLA may lead to an effective lumen with less dissection and an improved clinical outcome. So let's dive into that. We know calcium-associated complications are, it's a wide range of different complications which we see. Dissection I already mentioned. We have suboptimal outcomes, meaning rest stenosis, which then forces us to use a stent. Embolization with slow flow or even no reflow really has a real problematic situation in terms of acute ischemia and worsening the situation, perforations, incomplete stent expansion, and of course vessel recoil. So with all this, technical success at the end of the procedure may be limited. And this is what we definitely don't want to see, especially in these patients, with critical limb ischemia who are under high risk for major or minor amputation. So POBA, standard balloon angioplasty, we already know is not the way to go. POBA has many drawbacks. And you can see here how a conventional balloon opens. It forces a lot of stress on the vessel wall, meaning it really creates dissections. And these dissections could lead into flow-limiting dissection, which then force us to bailout stenting. And bailout stenting, especially below the knee, even if we use drug-eluting stents, are associated with restenosis and with multiple reinterventions. So we need to discuss on a more effective lesion preparation strategy, and this is what I would like to discuss and focus on. So post-PTA dissection below the knee is something we should avoid because it is associated with worse outcome in terms of technical success and clinical outcome. Typical case example here where I recanalized the posterior tip artery, and you could see here a lot of things going in here in the mid part of the posterior tip artery, like local thrombosis, dissection, and it's flow limiting. So I was forced to implant a TAC device here to keep this vessel open. So that means that we definitely need to talk, how can we maintain the lumen? How can we avoid of patency loss? We also are aware of vessel recoil. I would just mention a paper from 2014 from Dr. Baumann from Switzerland, who really nicely showed us that after 50 minutes, after standard balloon angioplasty, 97% of vessels recoiled and 29% of the lesions showed a significant recoil with loss of lumen. So therefore, I definitely would, for this part, POBA, standard balloon angioplasty, summarize, if we use POBA as a standard technique below the knee, we have to definitely deal with a lot of complication. It's a kind of vicious circle caused by standard balloon angioplasty in terms of insufficient lumen gain, recoil, and of course, barotrauma. There are now different devices on the market which help us to avoid all these technical outcome disasters. I just want to briefly summarize what we have seen recently during the congresses. For example, the temporary spur stent system, a stent system which is a self-expanding nitinol stent with integrated balloon. You see these mini spikes which really go deeply into the calcification, weakens the calcification while the balloon is inflated. And with that, the compliance of the vessel is improved. And with that, we see less recoil and less dissection. Just to show you a typical case example, which we then, after using the temporary spur system, used a drug-coated balloon, a Sirolimus balloon. You see here the temporary spur system for that lesion in the TP trunk. which we advanced here using a 6 French sheet 014 guide wire. Now we remove the cover of this temporary spur stent system, as you could see here. So without bringing too much force, it's very easy to remove this cover sheet. Then we inflate the balloon, which can be seen on the right side. And now the spikes dive into the vessel wall and weakens the calcification and improves compliance. Excuse me. And after this, we perform then drug-coated balloon angioplasty. And after this, no more significant stenosis can be seen. Excuse me. And no dissection, as you could see on the right side. Another device is the Serenader Balloon from Cagent Vascular. This balloon is a balloon which has 3, as you can see, serration straps on that balloon. And you can see that these serrating elements, while inflating balloon, are really forced into the vessel wall. And also with that, you improve compliance while you are cracking the calcification. So another option to improve compliance and to avoid dissection. Just to briefly show you a typical case, which we then used afterwards as a Sirolimus balloon, a solution balloon, to maintain patency. So you see an occluded posterior artery here in a patient with critical limb ischemia. The reference vessel diameter 3 millimeter, stenosis grade 100%, lesion length around 40 centimeter. This is the angio with showing the outflow within the posterior artery, so some feeding via collaterals. And I passed this occlusion with a guide wire and then used the Serenader. And you see, after using the Serenader for 2 minutes, no dissection, no recall. And then I used a solution balloon, drug-coated balloon, to maintain this patency after this good clinical and technical outcome. And this is the run of post drug-coated balloon angioplasty. So a case which I would like to show a little bit more in detail is the Sirolimus DCB angioplasty balloon knee case in a critical limb ischemia patient. And we used here in this case the CSI Shulze system, which is an atherectomy system. Just briefly summarize this system, this principle. It used crowns at the tip of a catheter, as you could see here on the left side. And as we are talking about a BTK case, I used here the micro crown. This is the tiny one here. So very small one, which you can use very efficiently below the knee for tibial artery interventions. So you see here the different peripheral crown types, also for SFA and popliteal artery interventions. On the right side, you see the micro crown, which is has a size of 1.25 millimeter, and excuse me. And with that, you can speed up this wire 1,000 rounds per minute, which then really debulks these lesions below the knee and removes the calcification. And this is the principle behind. So it's a dual mechanism of action, a sanding off of calcification below the knee. And after this, I personally believe, and based on what John just showed us, using a solution drug-coated balloon maintains patency. And with that, we have good chance to improve the patency for these patients and improve clinical outcome to achieve a wound healing in patients with critical ischemia. So this is already proved within the calcium 360-degree trial by the atherectomy company CSI. They really showed in a randomized fashion orbital atherectomy versus PTA alone in a 50 patient randomized 25 to 25, that especially, in terms of freedom from revascularization, mean max balloon pressure, freedom from major adverse events, very good, and especially freedom from major adverse events like peripheral embolization, recall, perforation, the dissection a very good and clinical good outcome. So this is something very important to mention at 12 months. And I personally believe with that starting evidence for solution therapy, we can really improve these great outcomes to combine lesion preparation with antiproliferative drug below the knee, for example, with the Sirolimus technology. And here's the case I would like to show you. This is a case of an 85-year-old lady with critical limb ischemia, D1 necrosis. I performed an integrated approach here using a 5 French sheet here. And this is the BTK runoff. And you see these high-grade stenosis, especially in the anterotip artery, posterotip artery occluded, peroneal artery patent, but definitely not sufficient to provide enough blood flow to the foot and forefoot. So our approach here was, which I just mentioned, using the CSI orbital atherectomy system, using the 1.25 micro catheter here, as you could see. And after atherectomy, then use drug-coated balloon angioplasty with this Sirolimus balloon. So we are prepping here the device, getting a wire into the anterotip artery, and now we are advancing the system. As you can see here, you see the micro catheter going down on the wire very slowly, forward, backward. This is the technique which we use so that the system can really remove the calcium, improve vessel compliance. And this you can do all the way down, all the 30 centimeters here within the anterotip artery. And in between, it's always important to flush, because when you are sanding off here this calcium, of course, microparticles, very, very tiny microparticles are released here, which are then flushed out through the microvascular bed, and you support this outwash with some infusion in between. So every 20 seconds, you flush and provides a good outflow of these microparticles. You see here, we already started proximal, then we advanced the system slowly forward, backward. Of course, with this 1.25 millimeter system, you can't create a 3 millimeter vessel lumen. I think that is clear. But this is not really the attempt with, or the result what we want to have. We want to improve compliance. And this is the principle of the different lesion preparation technologies, atherectomy, scoring technology, all these different devices, also including shockwave angioplasty. These devices, these techniques improve vessel compliance. And after this, you can then increase the lumen with standard balloon angioplasty, followed then by drug-coated balloon angioplasty. And my personal principle, and this is my personal approach, is make it open sufficiently, but also always think of keep it open. And so therefore, step 1 and step 2 are definitely very important. Therefore, lesion preparation, I personally believe, is the way we should definitely discuss, especially in calcified lesions, in BTK lesions, so that we avoid dissections, recoil, or slow flow, no free flow phenomena. You can see here we are diving more distally with this system here. At the moment with slow speed, meaning we are not giving full rotational speed here with that system. If the patient is not sedated, he does not feel too much, but when you increase the speed, sometimes the patient gets some tactile feedback, some strange feelings, and this could then lead to some movements. You see, we already performed here this atherectomy. There's still not perfect lumen, but again, this is just lesion preparation, so vessel compliance improvement. And this is always followed then with a low pressure balloon angioplasty, meaning 1-to-1 vessel size balloon ratio, with that, we then have the chance to avoid the dissection. And then I finalized these cases with Sirolimus drug-coated balloon angioplasty. We started here also again in the proximal part with a second attempt. Here you see there's still some residual stenosis. So we advanced the system here, especially proximal a little bit, to really get the most benefit out of that in terms of lesion preparation. Yeah? Important is, and you could see here with my finger, do it very, very slowly. So, and this is the outcome in the proximal part. Yeah? So, of course, still some significant stenosis. Yeah? Just to mention that, and to be definitely brave here, that is not the real attempt, and this is not that what we typically see. You don't see a lumen gain of 3 millimeter with the system. Yeah? So we then move the wire a little bit in also some side branches here of the dorsal pedal artery, and then also you see really getting as much as possible blood flow in the foot. This was definitely what we wanted to see here. Yeah, and then we performed standard balloon angioplasty with a standard balloon here, but only, as you could see here in the manometer, only with 4 atmospheres. We did not need more, because the compliance was already improved. And then we finalized that case with long DCB angioplasty, because I definitely thought that this is the most important vessel for this patient for giving blood supply and wound healing in the foot. And this is the outcome in the mid part. You see nice outcome after solution drug-coated balloon angioplasty, no recall, no dissection. Only in the proximal part, maybe a little bit, but definitely not significant. So therefore, in the proximal part, I thought, it's maybe important to enhance a little bit the patency, because there is a little bit dissection. Therefore, I decided to implant a very short, tiny tags. As you could see here, this is a 4-friend tag device. After atherectomy, Sirolimus drug-coated balloon angioplasty, just 2 of these very short tag devices, based on the TOVA 2 BTK trial, which was recently published, which really showed a nice outcome in terms of patency. I think it's a perfect combination of these different therapies of lesion preparation, followed then by drug-coated balloon angioplasty. And if there is still some tiny dissection remaining, then placing of these tags, and this is the final outcome here. In summary, I would like to definitely state we need more data, especially for this combination therapy. And as John mentioned, we are on the way to creating this evidence. For example, with the Success PTA trial, where we aim to include patients with claudication, also critical limb ischemia from SFA to the foot, 722 patients within 50 sites in Europe, Asia and South Africa, with the primary endpoint of clinical-driven target lesion revascularization at 12 months. And I think this is a good start-off point for creating evidence, but I think it's even more important to dive more into the CLI topic. And with the STEP trial, which John already mentioned, where Marianne Brodmann is the PI, a very interesting trial. I think we can even learn more about antiproliferative therapy using the Sirolimus technique, using this device in the foot and forefoot, so below the malleolus. And I think that is very interesting, because we do not have data, even not for the paclitaxel technology, below the malleolus. So I'm very thankful that Marianne brought up this study idea, so that we can learn also from this trial how antiproliferative drug therapy really improves clinical outcome in patients with below the malleolus disease. So in conclusion, I think it is important, especially below the knee, to perform a very intensive lesion preparation attempt using different technologies. So a debulking strategy, followed then by DCB technology, and based on the Prestige trial, And based on what we personally learned here in Arnsberg from the Sirolimus technique, I think this is a very good and helpful technique to maintain patency and improve clinical outcome. And only if we are forced to, then we implant very short, ultra short stents like the TAC device, so calling that a hotspot stenting. And hopefully with this technique, we can improve the clinical outcome in these most challenging patients, these critical limb ischemia patients. Thank you very much.
Thank you very much, Michael. Again, thank you both for the great talks. We have numerous of questions, but let's start directly with the results of the polls. Now let's see the first poll, and then we can discuss on them. So the question was, the drug-eluting balloons you use today are, and you see that 78% are using both paclitaxel and sirolimus balloons equally. So John, do you think that it is now the time that we will change, and in the next few years you will see that they are using mainly sirolimus balloons, or do you think that there is place for both type of balloons in PAD treatment?
Well, I think you'll see continuing improvement with the paclitaxel technologies. Remember that for the past, I guess maybe 10 years, I don't know exactly, the first generation designs used the crystalline paclitaxel, and this is a material that results in a little bit higher vessel injury. The crystals break off in large uncontrolled pieces, results in more distal embolization. So I think that there will be better paclitaxel devices coming on market. I think right now the opportunity is for all drug-coated balloon companies to move to a better types of coatings. And I'm convinced after much experience testing the amphipathic lipid technology, which is actually a way of adhering the smaller particle coatings to the vessel surface, that's the way to go, rather than having these relatively simple coatings that have a lot of large pieces of drug in the coating. So I wouldn't give up on paclitaxel, but I think we now know that we can use either drug successfully. And I mean, over time, we're going to have to see how the market or how the trials show the effectiveness of sirolimus versus paclitaxel. We have a lot more data right now on paclitaxel, but I think the sirolimus data is coming, and hopefully it's going to show that it's at least as good. In the coronaries, we've been able to pretty much use sirolimus exclusively because it's shown to have lower weight loss as compared to paclitaxel. So it performs better in coronaries, but in the peripheral arteries, we don't know yet. It's a different kind of physiology, as you well know.
Michael, do you think that until we have a randomized control trial comparing face-to-face paclitaxel to sirolimus for PAD, do you think that you will use both of them? Do you have any specific criteria, or are you still searching now for answers?
We are still searching for answers, of course, and I think it's way too early to really judge on these different technologies, and we need to be honest here. Yeah? I remember at the time, a couple of years ago, when we were very enthusiastic when we started with paclitaxel. So we only had efficacy in our mind, but we forgot, unfortunately, on the safety issue, and this now comes to our discussions, and I think we shouldn't do the same mistake also with the new sirolimus technology. So therefore, we should always focus on safety aspects while we are analyzing efficacy also for that. Until we don't have randomized controlled trials, I think it's too early to really say this technology is for this indication, that technology is for that indication. We know from theory, as John just mentioned and showed us very nicely, that there are definitely some kinetic aspects which definitely are much better for and count for the sirolimus technology. We need to see how this technology works in our daily routine. We will see this at the end of all these trials. It's great that you are doing that. These trials, these are very, very important, especially also below the malleolus, But at the moment, it's definitely, I think, too early to draw a conclusion based on that, what we have for evidence.
Okay, so next poll, please. The next was, do you believe that Sirolimus is a better drug than paclitaxel for treating PAD? You see, and I'm really great surprise for me, 70% says that they strongly believe Sirolimus is better. John, how do you comment on this? Do you think that you have convinced them?
Well, I'm surprised by the result too. I feel that we're just entering the peripheral vascular market with Sirolimus, and it required a lot of design change in order to get an effective device. We couldn't just simply spray it on the balloons and have a result. The early trials were just early designs that were tried, even in our shop, even in our company, were not all that successful. And so it's taken time to really realize how to use Sirolimus for the peripheral arteries, and how to get the extended release that we think is necessary to get a more effective treatment in peripheral arteries. So, you know, I'm of course a believer, having worked for 30 years with Sirolimus, that it's a better drug to use, but I'm quite biased. The early paclitaxel designs that I made, which we had offered at Biosensors, were not very effective, and so it took a lot of searching to realize that we typically could get lower late loss, lower restenosis with Sirolimus than we could with paclitaxel in the setting of coronary arteries. And I think other experience now, we have many large trials in coronary arteries that show that Sirolimus is just a much better drug. It results in lower inflammation and much lower late loss. But this is the coronary bed. These arteries are in a way much more predictable compared to what's going on. All the many things, as Dr. Lichtenberg pointed out, that happen when we're trying to treat peripheral arteries. So can Sirolimus be the magic bullet? I think there is no magic bullet. You have to combine therapies, as Michael said, and find the best overall protocol. The drug-coated balloon is only there to provide the long-term effect of controlling restenosis, but if the vessel isn't properly prepared, I don't think drug-coated balloons will really be all that effective, whether they're paclitaxel or Sirolimus. We need to do adequate lesion preparation.
Exactly, and this would be my question to Michael, because Michael, you have really nicely highlighted that vessel prep is a really important thing, and we have nowadays good tools to do a vessel preparation. Do you think at the end should ask ourselves what is the better drug, or should we ask ourselves what is the best or the better vessel prep method?
I think you have to. I think both. You have to combine these different aspects to one aspect. And as John mentioned, it's not, you know, a DCB is not helping you out of a bad outcome. If you have a bad technical outcome, DCB is not rescuing you. And therefore, I would always say is you have to get a very good technical outcome, and then you know, preserve this good technical outcome with a very good antiproliferative substance. I personally clicked here number 5. I'm not sure, because the evidence is not enough at the moment. It seems based on the theory, there are definitely arguments which advocates for Sirolimus in terms of preventing slow flow, no reflow, washout complications of the drug, you know, including microvascular beds. So this is something which definitely counts, especially for CLI patients, where we don't want to see that because they need this microvascular bed for wound healing. I think at the moment we need to set up trials, also trials which focus on lesion preparation plus DCB technology. There's not enough evidence for this combination therapy yet. There are some smaller registries, but not enough randomized trials. I think we have to set up these trials, and then perform subgroup analysis for claudicants, for CLI patients to learn how these two different technical aspects can be combined to really improve the clinical outcome for the individual patient.
Perfect. So let's see in the final poll. How often do you use a drug-eluting balloon to treat the SFA? And you can see that we are talking about 10 to 30%. I would suggest, I would, let's say, wait it for 30 to 50%, but it seems that there is no clear, let's say, trend here. It is a trend about 10 to 30%. Do you think that this is still the lack of evidence that making the difference?
I'm not sure. The question would be here, what is the standard therapy if someone is not using drug-eluting balloon angioplasty? Is it primary stenting then? Is this, the other half of the colleagues who said we are not typically use DCB? I don't know. And if you really bring a stent technology into the discussion, then I definitely have to admit we do not have data stent versus DCB. It's not existing. So therefore, I'm a bit surprised here that DCB technology is not so frequently used. Our approach here is to avoid stenting and to get out as much as we can without any stent implantation out of these cases, to maintain, or let me say, to give options for the patient for future treatments, because they are always coming back, these patients, with progressive disease. So if you don't implant stents, then you have definitely a lot of options in the future. Therefore, in summary, I must say I'm a little bit surprised here when I see this voting, actually.
Okay. So now I think it is time to, let's say, to respond to the audience, because we have some good questions, in my opinion. The first one is a very interesting question, and I think this goes directly to John. John, what is the difference between Solution and Magic Touch?
They're different designs, and so you certainly can't take some data from Magic Touch and say this is the way Solution will perform, and you can't take Solution data and say this is the way Magic Touch will perform. You have to look at each device individually and look at the clinical record, if you will. We have a bit more data in the peripheral applications right now as compared to Magic Touch, although I think the company is working hard to do some trials. And so I would look at the available data and clinically, and then try to make some judgment on your own which device to use. I could tell you that technically the particles that you find in Magic Touch are about a factor of 10 smaller. They're in the nanoparticle range. The lipid coating that they use is an animal-derived lipid, which has a different formulation and would have different properties in terms of ability to enclose the particles. The release is triggered by a different mechanism in the Magic Touch. It's based on a pH change, whereas in the Solution balloon, the release is really based on the time-honored principle that I learned from designing stents for many years, which is when you combine Sirolimus in molecular form with a nice polymer, a well understood polymer like PLGA, polylactic glycolic acid, in a sphere, you'll get a very uniform release from each particle, whereas the particles in the Magic Touch are many different sizes. They have a wide size range, so the release rate you're getting is an average of all the different particles that are encased in that balloon. So I do think we have, our testing, at least in animals, indicates that we have a longer, more sustained drug release than the Magic Touch. And so that's probably the biggest functional difference that you should be aware of. You get a longer, the release from the Magic Touch is a little bit faster, so you're treating maybe lesions where the requirement is to have more drug early and less drug late, whereas ours is a more uniform release over a longer period of time.
Okay. So, clear answer. Now it comes the second question for Michael. Do you recommend dual antiplatelet therapy after using Sirolimus coated balloons without any stenting?
We personally do it, but we do not have any data for this. So maybe we have some data from the company side itself, but based on our protocols, based on what we have so far seen in literature, there's no clear recommendation to use a dual platelet therapy after DCB angioplasty.
Okay.
John, is it something you would recommend definitely, or not?
John, do you recommend dual antiplatelet treatment?
This is certainly not my area of expertise, but I think that we see relatively rapid healing with drug-coated balloons in general. Normally there's a pretty rapid endothelialization after using a drug-coated balloon as compared to a stent. And I think this is a big advantage for the patient, which probably allows a shorter course of antiplatelet therapy. Regardless, I mean, we don't have data on which would be the best antiplatelet therapy, even with the various devices. But I think in general, we can say that a less rigorous antiplatelet therapy is used with drug-coated balloons as compared to a patient that you're treating with a stent, because there's better endothelialization early with drug-coated balloons.
Okay. So the next question is, I think, for John. Is the effect of Sirolimus regarding restenosis dose dependent? That means you are increasing the dose, probably he means the colic, and you have better outcome?
So this is an extremely interesting question, and one that I've investigated somewhat in our company at MedAlliance. And we tried two different doses, one a larger dose and one the dose that we're currently using now on our product. The larger dose was 3 times as much Sirolimus. And we haven't published this data yet, but I'm working hard to get it published. This is in a human trial, 50 patients on either side, this lower dose versus a larger dose. And this was a mix of coronary patients, both with in-stent restenosis as well as primary PCI and stable angina. And interestingly enough, we saw no difference in the restenosis result by going to 3 times the dose. And so I asked myself, why would we not get a dose-dependent result? And I think the answer from theory, at least I can argue, is that once you fill up all of the Sirolimus binding domains in the affected cells that are being activated by the injury, adding more Sirolimus, the extra Sirolimus just degrades and is harmlessly passed out of the system, because you have only so many binding sites. FKBP12 is the active a protein inside of cells that controls growth. And once you bind Sirolimus reversibly to all of these binding sites in the cells, adding more Sirolimus doesn't really make it any more effective. And so Sirolimus itself is so potent, as is paclitaxel, that nanomolar quantities of the drug, if you were to add it to a petri dish with growing smooth muscle cells, human smooth muscle cells, will be effective in stopping 50% of the proliferation. So from a cell mechanical standpoint, we know that even tiny amounts of Sirolimus once it reaches the affected cells, is effective. And so, as you know, we've been moving down the scale with stent designs where you see lower and lower doses of sirolimus and thinner struts. They're almost approaching what we do with drug-coated balloons. I mean, the designs now for stents have thinner and thinner struts and less sirolimus because we're finding that it's still clinically effective. So even in the case of stents, we're moving to smaller doses of sirolimus and still finding success. So we don't need to use a lot of drug is the end story to get a good therapeutic response.
Okay,
but
I think
it has to be there, and it has to be there for an extended period of time.
That makes sense. So, John, now I have a great challenge for you. You have only 20 seconds to explain us what is amphipathic coating. Only 20 seconds, please.
So amphipathic simply refers to the lipid molecules have two ends, and one end is charged in a positive way and one end is charged in a negative way. And so the coating has this ability to change its position in the coating from plus to minus. And as soon as the coating gets close to the negatively charged cholesterol, which makes up a large portion of a cell membrane, there's an electrostatic attraction between the positive end of the amphipathic molecule and the cell membrane, which allows it to basically dock, if you will, to the cell membrane and allow enhanced transfer. So we call this a drug absorption enhancer. So the practical functionality of it is that this charge, this electrostatic charge, is another method of increasing the drug absorption and the ability of the drug to cross the cell membrane and enter the cell where it actually exerts its effect.
So you're a genius. You really achieved to explain it in very few seconds, and I think it was clear. So by this way, I think we have covered the majority of the questions that we had, and I think that we have a clear message that Sirolimus came to our lives and will probably stay due to the first messages that it works really well. However, we have to wait for the ongoing trials, and I think, Michael, I will agree that there is not only the paclitaxel, there is not only Sirolimus, it is a vessel prep. So we have actually combination therapy. And it's what always you say in the congresses, please do not forget on vessel prep. So by this way, I would like to deeply thank you for your great talks. John, it was very important to have you here in order to understand the mechanism behind. We have more information about the solution in our exhibition area in Vascupedia. You can take more information about instruction for use, mechanism of action. The whole presentation today in the webinar will be from tomorrow uploaded in our website if you want to check again the talks of our guests. And I wish to everybody a great night. Thank you again for watching us. Michael, John, thank you very much.
Thank you. It was a pleasure.